Hello my dear students, our small group presentation today is about knee pain. Our references are PET's Guide to Physical Examination and History Taking, First Aid for the USMLE Step 1, 2016 student-to-student. Our learning objectives are to recognize the different anatomical structures of knee joints, identify the causes of knee pain, learn different characters and types of knee pain. First, I'd like to know the types of joints present in our body. There are three types of joints present in our body: synovial, cartilaginous, or fibrous. The synovial joints are freely movable joints, such as the knee and shoulder, lines with synovial membrane and contain synovial fluid. Cartilaginous, like slightly movable, like the vertebral bodies of the spine. And lastly, the fibrous ones are immovable, like the skull sutures. What about the anatomy of knee joints? You have to know the proper anatomy of the knee joints, the articular structures and the extra-articular structures, because these are the sources of knee pain. What about the articular structures? Articular structures involving the knee capsule, the articular cartilage, the synovial lining, the synovial fluid inside the joints, and the interarticular ligaments, the extra-articular bones. The extra-articular structures or periarticular structure involving the ligaments, the tendons, bursa, muscles, fascia, bones, and nerves. I'd like to tell you about this important video about the anatomy of knee joints, also the mechanics of knee movements in the YouTube. This is the link for the YouTube channel to see this video. It's very important video.
A well-functioning knee joint is critical to mobility, including standing, walking, and running. To better understand how knee problems occur, it is important to understand some of the anatomy of the knee joint and how the parts of the knee work together to maintain normal function. The important structures of the knee can be divided into several categories. These include bones, joints, ligaments, tendons, muscles, nerves, and blood vessels. First, let's define some common anatomic terms as they relate to the knee. This will make it clearer as we talk about the structures later. Many parts of the body have duplicates, so it is common to describe parts of the body using terms that define where the part is in relation to an imaginary line drawn through the middle of the body. For example, medial means closer to the midline, so the medial side of the knee is the side that is closest to the other knee. The lateral side of the knee is the side that is away from the other knee. Structures on the medial side usually have medial as part of their name, such as the medial meniscus. The term anterior refers to the front of the knee, while the term posterior refers to the back of the knee. So the anterior cruciate ligament is in front of the posterior cruciate ligament. The knee is the joint where the femur and the tibia meet. The patella, or kneecap as it is commonly called, is made of bone and sits in front of the knee. The knee joint is a synovial joint. Synovial joints are enclosed by a ligament capsule and contain a fluid called synovial fluid that lubricates the joint. The end of the femur joins the top of the tibia to create the knee joint. Two round knobs called femoral condyles are found on the end of the femur. These condyles rest on the top surface of the tibia. This surface is called the tibial plateau. The outside half, the farthest away from the other knee, is called the lateral tibial plateau, and the inside half, closest to the other knee, is called the medial tibial plateau. The patella glides through a special groove formed by the two femoral condyles called the patellofemoral groove. The smaller bone of the lower leg, the fibula, never really enters the knee joint. It does have a small joint that connects it to the side of the tibia. This joint normally moves very little. Articular cartilage is the material that covers the ends of the bones of any joint. This material is about 1/4 of an inch thick in most large joints. It is white and shiny with a rubbery consistency. Articular cartilage is a slippery substance that allows the surfaces to slide against one another without damage to either surface. The function of articular cartilage is to absorb shock and provide an extremely smooth surface to facilitate motion. We have articular cartilage essentially everywhere that two bony surfaces move against one another or articulate. In the knee, articular cartilage covers the ends of the femur, the top of the tibia, and the back of the patella. Ligaments are tough bands of tissue that connect the ends of bones together. Two important ligaments are found on either side of the knee joint. They are the medial collateral ligament, or MCL, and the lateral collateral ligament, or LCL. Inside the knee joint, two other important ligaments stretch between the femur and the tibia. The anterior cruciate ligament, or ACL, in front, and the posterior cruciate ligament, or PCL, in the back. The MCL and the LCL prevent the knee from moving too far in the side-to-side direction. The ACL and the PCL control the front-to-back motion of the knee joint. The ACL keeps the tibia from sliding too far forward in relation to the femur. The PCL keeps the tibia from sliding too far backward in relation to the femur. Working together, the two cruciate ligaments control the back and forth motion of the knee. The ligaments, all taken together, are the most important structures controlling the stability of the knee. Two special types of ligaments, called menisci, sit between the femur and the tibia. These structures are sometimes referred to as the cartilages of the knee. But the menisci differ from the articular cartilage that covers the surface of the joint. The two menisci of the knee are important for two reasons. One, they work like a gasket to spread the force from the weight of the body over a larger area. And two, they help the ligaments with stability of the knee. Imagine the knee as a ball resting on a flat plate. The ball is the condyles of the femur, and the plate is the tibial plateau. The menisci actually wrap around the round condyles to fill the space between it and the flat tibial plateau. The menisci act like a gasket, helping to distribute the weight from the femur to the tibia. Without the menisci, any weight on the femur will be concentrated to one point on the tibia. But with the menisci, weight is spread out across the tibial surface. Weight distribution by the menisci is important because it protects the articular cartilage on the ends of the bones from excessive forces. Without the menisci, the concentration of force into a small area on the articular cartilage can damage the surface, leading to degeneration over time. In addition to protecting the articular cartilage, the menisci help the ligaments with stability of the knee. The menisci make the knee joint more stable by acting like a wedge set against the bottom of a car tire. The menisci are thicker around the outside, and this thickness helps keep the round femur from rolling on the flat tibia. The menisci convert the tibial surface into a shallow socket. The socket is more stable and more efficient at transmitting the weight from the upper body than a round ball on a flat plate. The menisci enhance the stability of the knee and protect the articular cartilage from excessive concentration of force. Taken all together, the ligaments of the knee are the most important structures that stabilize the joint. Remember, ligaments connect bones to bones. Without strong, tight ligaments to connect the femur to the tibia, the knee joint would be too loose. Unlike other joints in the body, the knee joint lacks a stable bony configuration. The hip joint, for example, is a ball that sits inside a deep socket. The ankle joint has a shape similar to a mortise and tenon, a way of joining wood used by craftsmen for centuries. Tendons are similar to ligaments, except that tendons attach muscles to bones. The quadriceps tendon connects the large quadriceps muscle of the thigh to the patella. This tendon continues across the patella, or kneecap, and blends into the patellar tendon. The patellar tendon connects the patella to the tibia. The hamstring muscles on the back of the thigh also have tendons that attach in different places around the knee joint. These tendons are sometimes used as tendon grafts to replace torn ligaments in the knee joint. The extensor mechanism is the motor that drives the knee joint and allows us to walk. It sits in front of the knee joint and is made up of the patella, the patellar tendon, the quadriceps tendon, and the quadriceps muscles. The four quadriceps muscles in front of the thigh are the muscles that attach to the quadriceps tendon. When these muscles contract, they straighten the knee joint, such as when you get up from a squatting position. The way in which the kneecap fits into the patellofemoral groove on the front of the femur and slides as the knee bends can affect the overall function of the knee. The patella works like a fulcrum, increasing the force exerted by the quadriceps muscles as the knee straightens. The hamstring muscles are the large muscles in the back of the thigh. When these muscles contract, the knee bends. The most important nerves around the knee are the tibial nerve and the common peroneal nerve in the back of the knee. These two nerves travel to the lower leg and foot, supplying sensation and muscle control. The large sciatic nerve splits just above the knee to form the tibial nerve and the common peroneal nerve. The tibial nerve continues down the back of the leg, while the common peroneal nerve travels around the outside of the knee and down the front of the leg to the foot. Both of these nerves can be damaged by injuries around the knee. The major blood vessels around the knee travel with the tibial nerve down the back of the leg. The popliteal artery and the popliteal vein are the largest blood supply to the leg and foot. If the popliteal artery is damaged beyond repair, it is very likely the leg will not be able to survive. The popliteal artery carries blood to the leg and foot. The popliteal vein carries blood back to the heart. The knee has a somewhat unstable design, yet it must support the body's full weight when standing and much more than that during walking or running. So it's not surprising that knee problems are a fairly common complaint among people of all ages. Understanding the basic parts of the knee can help you better understand what happens when knee problems occur.
For you. To evaluate the knee pain, you must characterize the patient complaint, whether it is articular or extra-articular, inflammatory or non-inflammatory, acute or chronic, according to the duration of pain, localized to the knee joints only, or diffuse involving the knee and the other joints. The articular diseases involving the knee joint characterized by presence of swelling and tenderness of the entire joint, may be associated with crepitus, clocking or instability of the knee joints, deformity, a limitation of both active and passive range of motion due to stiffness or pain. Extra-articular disease, this involving a point or a local tender point in the region of adjacent to the articular structure with limitation of active range of motion, not the passive one, and rarely causes swelling and instability, joint deformity. What about the acute and chronic knee pains? Acute means the duration of pain less than 6 weeks, and chronic the duration are more than 12 weeks. May involve the knee only, and hence we call it monoarthritis, or involve the knee and other joints such as hip or ankle, and call it polyarthritis. Acute monoarthritis, the example for this type of knee pain with pyogenic gout, pseudogout, acute rheumatic fever, trauma, writers, psoriasis, rheumatoid arthritis, and hemophilic arthritis. Acute polyarthritis, such as acute rheumatic fever, pyogenic, SLE, serum sickness, writers, psoriatic, ankylosing viral leukemia. Chronic monoarthritis, such as osteoarthritis, pseudogout, gout, and vascular necrosis, tumors, chronic infection. Chronic polyarthritis, like rheumatoid, gout, pseudogout, osteoarthritis, and psoriatic, ankylosing, SLE, other connective tissue disorders, and neuropathic joints or Charcot joints. The knee pain may be inflammatory or mechanical. The differentiation between both types are according to the morning stiffness. If the morning stiffness more than 1 hour associated with a profound fatigue, improves with activity, worsens with rest, associated with systemic manifestation, and improves well with corticosteroids, we call it an inflammatory knee pain. But if the morning stiffness is less than 30 minutes with minimal fatigue, worsens with activity, improves with rest, associated with no systemic manifestation of inflammation, and not improved with corticosteroid, we call it mechanical knee pain. So the pain characteristics is very important. We would like to know the onset, if it is a rapid onset or insidious onset of pain, the site of pain, whether it's anterior, medial, lateral, or posterior knee pain. The duration is very important to differentiate between the acute and chronic knee pain. The severity, mild, moderate, severe. The type of knee pains, dull aching, sharp, burning, throbbing. The aggravating factors and alleviating factors also need to be identified. We reach to the differential diagnosis of knee pain according to the age groups. We divided it into 3 categories: the older adults, young adults, and children's. The most common causes of children and adolescents knee pain are patellar subluxation and tibial epiphysitis, jumper knee, osteochondritis dissecans, GIA, and trauma. Referred pain also common in this age category, like these slipped capital femoral epiphysis and Percy's disease and hip fractures. While young adults, the most common cause of knee pain are patellofemoral pain syndrome, chondromalacia patelli, medial pelvic syndrome, Pearson bursitis, inflammatory arthropathies like rheumatoid arthritis, pigmented villonodular synovitis, trauma like ligamentous sprains, meniscal tears and fractures, tendonitis, quadriceps or patellar tendonitis, septic arthritis. But the old age osteoarthritis is the main cause of knee pain. Crystal-induced inflammatory arthropathy like gout and pseudogout, popliteal cyst, and metastatic cancers are the most common causes of knee pain in old age. According to the anatomical site, we classify the knee pain into anterior knee pain caused by patellar subluxation dislocation, tibial epiphysitis, jumper knee, and patellofemoral pain syndrome. Medial knee pain involving the medial collateral ligament sprain, medial meniscal tear, Pearson's bursitis, medial pelvic syndrome. Lateral knee pain involving the lateral collateral ligament sprain, lateral meniscal tear, iliotibial band tendonitis. The posterior knee pain involving the Picker cyst, popliteal cyst, posterior cruciate ligament injury. The differential diagnosis according to the mechanism of injury, whether it is traumatic or atraumatic. traumatic causes involving the ligamentous strain or sprains, fractures of femur or tibia, fibula or patella, meniscal tear, patellar subluxation, muscle strain, and osteochondral fracture. Atraumatic causes may be degenerative or inflammatory, like osteoarthritis, rheumatoid, and other inflammatory arthritis, septic arthritis, stress fractures, tendonitis, patellofemoral syndromes, medial pelvic syndrome, and referred pain from the hip or lower back, metastatic cancer. All these are traumatic causes for. So, your accurate diagnosis requires knowledge of the knee anatomy, common pain patterns in the knee injuries, and features of frequently encountered causes of knee pain, as well as specific physical examination skills. Your history should include the characteristic of patient's pain, mechanical symptoms like locking, popping, giving way, joint effusion, the amount of joint effusion, whether it is mild, moderate to severe, the recurrence of joint effusion is very important, the timing of knee effusion also is very important, and mechanism of injury may be involved also in your history. The physical examination should include careful inspection of the knee, palpation for point tenderness and assessment of joint effusion, range of motion testing, evaluation of ligaments for injury or laxity, and assessment of menisci. Here's a link for the YouTube channels for physical examination of the knee joints. Very important video. You should see to know the proper physical examination, inspection, palpation, and range of motion, and special tests for ligaments injury in the joint.
Hi there, my name's Andrew. I'm one of the final year medical students. Could I just confirm your name and date of birth, please?
Sure, it's James, 131289.
Nice to meet you, James. Today I've been asked to examine your knees. This will just involve watching you walk, then inspecting both knees. I'll then feel around the knee joints, and then I'll assess the movements in both knees as well. Would that be okay?
That sounds fine.
Do you have any pain at all before we start?
No, I don't.
Fantastic. We can begin the exam. James, I'm just going to feel both knees now. Do let me know if you have any pain at all. Okay, James, time for some movements now. Could you bend your right knee as much as you can for me? And now straighten the leg back out. And same on the left hand side. And back out. Okay, James, we're going to do the same movements again. However, this time I'm going to move your leg for you. Just stay as relaxed as possible. Same on the other side. And now, James, I'm going to lift each leg, starting with the right. Okay, James, if you could just bend the right leg for me, keeping your foot on the bed. And relax it down. And the same on the other side. James, I'm now going to lift each leg and apply some pressure to the front and the back. Do let me know if there's any pain at all. I'm now going to lift each leg and apply some pressure to each side. Just stay as relaxed as possible. Okay, James, that completes the examination. Thank you very much.
Okay, thank you.
Today I performed a knee exam on James, a 27-year-old male. James had a normal gait and on inspection had no obvious deformities of either knee. On palpation he had no pain and had a full range of active and passive movements. This was a normal knee exam. To complete my examination, I'd like to examine the hip, the ankle, perform a neurovascular examination of both lower limbs and look at any available imaging.
So our summary is the teenage girls and young women are more likely to have patellar tracking problems such as patellar subluxation and patellofemoral pain syndrome. Teenage boys and young men are more likely to have knee extensor mechanism problems such as tibial epiphysitis and patellar tendonitis. Referred pain resulting from the hip joint pathology such as left femoral epiphysis also may cause knee pain. Active patients are more likely to have acute ligamentous sprains. Trauma may result in acute ligament rupture or fracture, leading to acute knee joint swelling and hemarthrosis. Septic arthritis may develop in patients of any age, but crystal-induced inflammatory arthropathy is more likely in adults. Osteoarthritis of the knee joints is more common in older adults. Thank you for your attention. Any question, you should write this question and send to me at the group, WhatsApp group. And thank you again for your attention.